Hello and welcome. Thank you so much for joining us today on this webinar. My name is Carrie Graham, and I'm the director of Georgetown's Medicare Policy Initiative. So, welcome. Our webinar today will give us a chance to focus on beneficiary choice in Medicare Advantage. In particular, we'll be looking at how beneficiaries choose plans and what the most recent 2027 proposed rule might change in terms of how the information and tools and resources that folks looking to shop for a Medicare Advantage plan, what might change for them. So for those of you who are new to MPI, we're an initiative within Georgetown's Center on Health Insurance Reforms. Our team focuses primarily on Medicare Advantage policy. We conduct research, we do policy analysis, and provide technical assistance to policymakers, with the goal of always strengthening Medicare, in particular, the coverage, lowering costs both for the federal government and for beneficiaries. And as with today's webinar, focusing on bringing meaningful, informed choices and improving those tools for beneficiaries who are choosing plans. Today's sort of special because we were very pleased to work with the SCAM Foundation to create what we're calling our Medicare Advantage Enrollee Advisory Group, with the understanding that we don't get enough input on Medicare or Medicare Advantage from people who have lived experience with the program and people who are choosing a plan. So we were able to recruit around 20 Medicare Advantage beneficiaries. And we had our first meeting. All of them are MA enrollees from across the country. And all are pretty savvy and well experienced in choosing a plan. Our first meeting was this November, so it was in the middle of open enrollment, and it was just incredibly informative for us, especially as we review some of the proposed changes in the MA and Part D rule that recently came out that could have some effect on beneficiaries' ability to choose. So this webinar is also brought to you by support of Arnold Ventures. So before we get started with today's conversation, I'm going to go over a few housekeeping matters. So first, we're recording this webinar and we'll share a link with anyone who's registered. If you like the webinar, you can feel free to share it with others in your network. The chat is also open if you want to introduce yourself or have any technical issues to flag for us. Otherwise, we'll keep an eye on it. As we'll be also posting our links to a few key resources that we may refer to in this webinar. And finally, we've tried to build in a lot of time to take your questions. So if you have questions at any point, please click on the Q&A button and you can type them in there and we'll either read them out and address them with verbally or respond in the Q&A. So I'm excited to introduce you today to our panelists. So, as I mentioned, we have done our first convening of our expert MA enrollee advisory group, and we're so grateful today to have Bill Cielo, who was he was part of our advisory group, and he lives in Kansas City, Missouri. He's a retiree, and I would say, he had just so many insightful insights on his experience with open enrollment. And so he's going to be here today, really giving us a firsthand lived experience and insights into what's working with the process and how to improve the process. Second, we have Jack Hoadley. He's a research professor emeritus here at Georgetown University. Some of you may remember him when he was a commissioner on MedPAC. He is, in addition to an important member of our MPI team, he also acts as a State Health Insurance Assistant Program, or SHIP counselor. And he'll talk a little bit about that, but the SHIP counseling program is a national program that provides one-on-one counseling, education, and outreach, and is an important source for beneficiaries, families, and caregivers during open enrollment and really all year long. Jack's also a Medicare beneficiary. And lastly, we have last but not least, we have Laura Skopec, who's a consultant at MPI and also a senior research associate at Urban Institute's Health Policy Division. Laura's going to kick us off today and give us just a brief overview of the landscape of MA decision making, some of the tools and resources, some of the current rules around that, and then kind of dive into what we're seeing as some of the proposals in the most recent MA and Part D proposed rule that could change some of these resources and tools. Obviously, you all know this is just the proposed rule at this point, and comments on this rule are due January 25th, I believe. And then we're going to move to a panel discussion where I'll ask a couple questions and then we'll get to your the audience questions. So I am going to hand it over to Laura right now to level set and start us off.
Thank you, Carrie. So as Carrie said, I'm going to kick us off with a bit of background on the tools consumers can use to help them make Medicare enrollment decisions and how the 2027 Medicare Advantage and Part D proposed rule might affect those tools. Next slide, please. So there's a variety of ways that consumers can get help to compare their Medicare options and make their enrollment decisions. I'm going to go through each of these, describe some of the known problems with each of these tools, and then go through what CMS proposes to change about them. So next slide. Starting with the CMS-supported decision tools, so these are things like Medicare.gov, which is also called the Medicare Plan Finder, the Medicare and You Handbook, and the 1-800-Medicare hotline. These are free to beneficiaries, and they're designed to provide neutral information and support for choosing Medicare options. The biggest problem with these tools is honestly that beneficiaries just don't use them very much. The information can also be somewhat limited, so it can be difficult for beneficiaries to really dig in on things like provider networks, prior authorization, denial rates, etc. CMS did try to add provider network data to the Plan Finder in 2025, but the first year was pretty bumpy. There was some incomplete and misleading information in there. There's also CMS creates these star ratings that are supposed to help beneficiaries assess plan quality. And those are provided on the Plan Finder, but they're a bit too high level to really help beneficiaries choose among specific plans. So out of these issues, the 2027 proposed rule really only addresses star ratings. So CMS is proposing to reduce the number of quality measures that are included in the star ratings. They're particularly focusing on removing measures that don't vary much across plans. That's a reasonable approach, but as part of that, they are disproportionately removing measures of plan behavior like disenrollment, appeals, complaints, customer service ratings, and focusing more on clinical measures like flu shots and mammograms and those kinds of things. So losing some of those plan-focused measures will make it a little harder for beneficiaries to tell which plans are more difficult to work with. CMS is also proposing not to implement new measures that were included under the prior administration that would have helped beneficiaries see how star ratings vary across certain subgroups, like for dual eligibles or for certain racial and ethnic groups. Next slide, please. As far as enrollment counseling, research says about 30% of Medicare beneficiaries get help from an insurance agent or broker. These can be independent or people employed specifically by an insurance company, and they're generally paid on commission. So part of the problem here is that agents brokers might have a financial incentive to sell Medicare Advantage plans over traditional Medicare because of higher commissions. There are also just bad actors in the agent and broker space that might enroll people without fully explaining their options or enroll people even without their consent. Agents and brokers also don't have to sell every plan available in a market, but it's not necessarily clear to beneficiaries what they might be missing out on. There's also just very little data about who uses agents and brokers and how they might affect decision making. So because of some of these issues, CMS has previously tried to increase disclosure requirements and add waiting periods to help make sure beneficiaries are getting accurate information and know what they're getting into. 2027 proposed rule mostly drops or relaxes some of these requirements. So CMS is proposing to drop requirements for a waiting period between educational events hosted by agents and brokers and enrollment events. In the same vein, they're proposing to relax some of the agreements and disclosures that beneficiaries have to sign before they work with an agent and broker. The administration is also requesting information on how to modernize their approach to regulating agents and brokers with a specific focus on reducing burdens. So next slide. The other enrollment counseling resource is the State Health Insurance Assistance Programs, or SHIPs. So these organizations are funded by federal grants to provide assistance to Medicare beneficiaries, both in person or over the phone. They're generally staffed by trained volunteers who have no financial stake in what the beneficiaries are choosing. But SHIPs are underfunded and it can be really difficult to access. They don't really advertise, so most beneficiaries don't even know they exist. And because of this limited funding, there can be waiting lists to get help from a SHIP during open enrollment. Might be noticing a pattern here, but the 2027 proposed rule doesn't really address those problems. So CMS is proposing to remove requirements for third-party marketers to tell people that SHIPs exist and that they can get help from them for free. There is also a request for information, like I mentioned, for the agents and brokers that kind of implies that agents and brokers might be a better source of information than SHIPs. CMS has proposed reducing SHIP funding in the past, but that's not part of this current rule. Next slide. So direct-to-consumer advertising is an important part of the Medicare information ecosystem, even if it's maybe an annoying part for beneficiaries. So Medicare Advantage plans and third-party marketers run ad campaigns on TV, social media, in print. They do direct mail, web advertising. Some of these ads are specifically designed to collect phone numbers so that marketers can then make direct sales calls. I think most beneficiaries could tell you themselves what some of the problems are with this market. So some ads are misleading, maybe even outright incorrect, and beneficiaries can sometimes be bombarded with sales calls, dozens a day from some sources. Unfortunately, CMS has really limited authority to regulate third-party marketers. They can regulate the Medicare Advantage plans, but not necessarily the third parties they work with. So it's been very difficult to rein in these problems. It's also pretty unclear how much money is being spent in this market. So the 2027 proposed rule takes a largely deregulatory approach to marketing in Medicare. CMS is proposing to relax rules on marketing disclosures and reduce requirements around recording sales calls. They're also asking for comment on just not requiring sales calls to be recorded entirely. They're proposing to remove a prohibition on what's called superlatives in marketing. So MA plans going forward might be able to say things like, this is the best MA plan in DC, and they wouldn't have to prove that they can back that up. CMS is also proposing to remove requirements that plans notify beneficiaries of any supplemental benefits that they have access to but haven't used in the middle of the year. And then this request for information again that's embedded in the proposed rule seeks comment on how to oversee third-party marketing and reduce burdens while also holding bad actors accountable. Next slide, please. We don't really have data to know how many people are using third-party websites and tools to help them make enrollment decisions, but these kinds of e-brokers have been growing. So one of the major issues is that they don't include all plan options available in each market. They might even completely exclude traditional Medicare as an option and only sell Medicare Advantage. Also, recently, the Department of Justice accused some of these sites of using AI to try to predict the profitability of potential enrollees and then steer people towards more or less aggressive sales tactics. The proposed rule doesn't really directly address these sites, but the loosening of rules around disclosures and notice requirements would apply to these types of e-brokers. Next slide. So there are some of the options available to beneficiaries if they feel like they've been misled or enrolled in a plan that just doesn't meet their needs. From January to March each year, everyone enrolled in Medicare Advantage has the opportunity to pick a new plan or switch to traditional Medicare. There's also a special enrollment period if a Medicare Advantage plan changes its network mid-year. But under current rules, that's only available if CMS considers that network change significant. In general, researchers have shown that most beneficiaries just don't know their rights. They don't tend to file complaints. They don't really attempt to switch plans very often. And rules around Medigap can make it very difficult or very expensive to switch out of MA and get back into traditional Medicare. The 2027 proposed rule does make a positive change on this front. They are proposing that the special enrollment period for network changes would be available to anyone whose provider leaves their MA plan. So you wouldn't need CMS to agree that the network change is significant. CMS is also proposing to consolidate some of the notice requirements for provider network changes and special enrollment period options to make them a little more clear and consolidated for beneficiaries. Next slide. So this change to special enrollment periods is a positive one for beneficiaries and should help people who experience network changes in the middle of the year. Simplifying star ratings is also a worthwhile goal. It's trying to make them more relevant for beneficiaries, but removing the administrative measures of things like disenrollment and appeals and complaints could make it a little harder to tell how well these plans are run or how difficult it will be to get care in those plans. But overall, the 2027 proposed rule really focuses much more on reducing administrative burdens for plans and their third parties that help them market their services more than on supporting beneficiaries to make better choices. But CMS does have requests for information on how to better oversee third-party marketers, and that's an important opportunity to potentially put forward some ideas that could reduce beneficiary burdens in making choices and make it easier to make good enrollment decisions. I will turn it back over to Carrie to open it up for discussion.
Thanks for that overview, Laura. And I also just want to again say for our audience, please put questions in the Q&A and we will get to those in a bit. But I want to start with some questions for our panelists. And Jack, we'll just start with you. You are a Medicare expert, but you're also a SHIP counselor, which I understand is a volunteer position. And can you just tell us a little bit more about what SHIP counselors are, how they're a little different from agents and brokers, and maybe why you want to be one?
Yeah, thank you, Carrie. I'm happy to talk about that. I had, when I officially retired, although I continue to work part-time, one of the things I thought I wanted to do was to become a SHIP counselor. I've worked on the Medicare program in one way or another for all my working career, really. And going back to days when I didn't really know what Medicare was, but had to learn it so I could explain it to other people. And I've always thought that the SHIP program was a valuable resource and a resource that was really important to beneficiaries. So I thought that was one of the ways I could give back. Most of those who serve as SHIP counselors are volunteers. We come from all kinds of backgrounds. Some have the kind of extensive knowledge that I do, and some others that I know have worked on Medicare over their lives and have decided to go into counseling. Others may have worked in a medical office, helped their patients or their boss's patients, navigate the insurance system and the Medicare system. Others may have worked in corporate benefits offices or been social workers or attorneys or other kinds of things where they had exposure to Medicare in the program. And so I think we're all kind of motivated to try to help. It's a process that's very rewarding at times and also very humbling at times. It's very rewarding because you really do get a sense of helping somebody walk through the issues, go from a point of just not even really knowing what they're supposed to do to having a good glide path to know how to make their decisions. It's also humbling because as much as I thought I knew and understood the Medicare program, I get questions regularly that I'll say, oh my goodness, I've never heard that question before. I don't know the answer to it. What I do have is the ability to go figure out the answer. And that's what we try to provide, even if we get questions that we don't know because it's some exotic corner of the program, we know how to look up the answers. And so typically I'm a volunteer that has a session one day a week. So I work for maybe a 4 to 5 hour period, taking phone calls from beneficiaries or soon to be beneficiaries, answering their questions. The two big areas that we take are probably people who are brand new to Medicare, either they're just turning 65 or retiring from work, or it's during that open enrollment period in the fall when they've got to reconsider what decisions they're in. And then probably the third bucket of inquiries are just miscellaneous things, Maybe they've got been getting post-acute care after a hospital stay, and that coverage for that stay has been terminated. They wonder what they can do about it. Or it's somebody who's about to move overseas and wants to know whether they continue to use Medicare once they've moved overseas, or somebody's moved back from being overseas. So lots of these other situations come up, and those are probably the three buckets of situations that we deal with the most.
Thanks, Jack. And we have a question from an attendee that's similar to a question I wanted to ask you. The question from the attendee is that they find SHIP hard to access in their region and feel like kind of giving up. How can why is it hard to access SHIP? I personally, I know they're called different things everywhere. They have different names, but why is it hard right now to access SHIP counselors who we know are, the ones that are not getting commissions and don't have a financial incentive to steer people to one plan or the other. So what are the barriers there?
I think the biggest barrier is just our inability to get the word out. For the most part, we don't have a budget that allows a lot of advertising. I know some counties do better. Some counties, most of these programs are run down at the county level. For very tiny counties, they may bundle a few counties together and work as a group to offer a program. But that's where it gets hard. And so I do SHIP counseling in Fairfax County, Virginia. And as you mentioned, we all have different names. So our Virginia plan is called VICAP. We're a big county of 1 million people, but we still only have a small budget. And so we don't have the ability to do a lot of advertising and general media. And so, the word gets out through word of mouth. It gets out through programs at public libraries. Some of the senior newsletters, senior communities, senior centers may publicize us, but we're not that well known, and that is a challenge. We also do our process by telephone, so people typically have to call the main number and then leave a message, and then we call them back, and that can be challenging because people don't always want to take calls from numbers they don't recognize. So that becomes a challenge just in calling somebody back. And when we do get them, we have great conversations with them, but it is hard to get the word out. And then there are barriers with language difficulty. We don't always have the ability to refer somebody to a counselor in their native language. So there are a lot of barriers, and more funding for the SHIP program would help. I did a little calculation that suggests that on average, the county budget that comes from federal dollars is only about $20,000 or $25,000 per county. And that's just not a lot of dollars, especially for a large county.
Thanks, Jack. I want to turn to Bill now. Bill, you were very kindly participated in our enrollee advisory group, and I just remember being very impressed with how savvy you were and how many different sources of information and tools and resources you accessed in order to feel comfortable making the right choice for yourself this year. So I'd love it if you just took our audience through kind of your process for making a choice in this open enrollment period.
Right, that's great. Yeah, Laura actually covered a lot of the issues that I went through, a lot of the different functions that I resorted to find out what was happening in this realm. So, starting with the direct to consumer, as Laura mentioned, I pretty much don't look at any of that. Like if I get stuff in the mail, it's pretty much recycled. And a lot of that stuff I just felt like didn't have much credibility. If I get phone calls, and as you said, we get inundated with calls and mailings, and so it's almost too much to really try to digest. So the first place I went, and it's delivered fairly timely, is the Medicare to You handbook. That was mentioned as well. It's kind of information overload. It's a very thick booklet. It's got a lot of information in it. Unfortunately, since it is in written form, it's not able to be sorted per se that way, and so it's a little bit cumbersome. It's best perhaps as a resource, I think, more than anything at some point if you just have something you want to target and look into. So I moved on to Medicare.gov and the online plan finder. I found it to be good, but it has a lot of limitations, especially with the comparative tools that are built into it. For example, you can only do 3 plans at a time. And I found it a little bit cumbersome as well as when you, let's say you look at three and then you're like, well, let's see, I'm going to get rid of that one and add another one and do this or do that. It seems like there's re-entry required for a lot of your parameters to get things to roll again. So that gets a little bit frustrating at times, a lot of re-entry that seems like it shouldn't be necessary. The comparison format's pretty good. It does lay out when you get the three, if you have them there and you want to look at it, but it's not all the variables that you want to really consider, or at least there's some, besides the major ones, there are some other things that you want to look into that just don't readily make the chart to go through. So the next thing I did, and I just got this through a mailing from my, of all places, my grocery store that I frequent, sent me information on a broker. And so I kind of went that route for a while, and only to find out, as was also mentioned by Laura, is that after I got partway through and I was doing plan comparison, I wanted to see it compared to my existing plan, find out that my plan, they don't have a association with my plan, and so it's not included in any of their data. They don't represent that plan. So I understand they're supposed to disclose that, but that was never disclosed to me until I asked the question. So I thought that was a little bit of a problem. The agent was very helpful, and they do a lot of work for you, and they'll get a lot of information for you. But again, they're limited in what they can do, and they do propose a best fit for you from what they have available to them. So the next thing I did, I get, like you said, SHIP is hard to. I never heard of SHIP until this year. I'm just basically thumbing through my library catalog, which I do regularly, looking for things to do, hobbies, whatever, cooking classes, whatnot. But there it was, SHIP, and I was like, oh, they'll, read about it. They'll help you with your Medicare enrollment. I thought I can always learn more. So I signed up. You have to register. You call up. You get an appointment. You roll in there, and it's a volunteer counselor, as Jack said. They're very helpful. The one I got was extremely experienced. In her work environment, she had done a lot of work in that area, so she was very helpful, had a lot of industry experience. I was able to ask questions. She was a good listener, and it all kind of worked. But their resources are also limited. When they kick out a compare, they're basically using the Medicare.gov. They don't have access to other tools. And when I would ask about these tertiary things that I wanted to know about and I wanted to include in my comparison, she would have to scribble them down on a piece of paper. And my brain was just, I have an accounting and finance background, and I just wanted to, you guys need a spreadsheet or something that you can put all this stuff in, that you can show somebody all these things and do a compare. But as she said, they have very limited resources, and that wasn't really something that was readily available to her. So there's just some other features that you want to know about, for example, the give back and other things that come into play that don't readily provide themselves, make themselves available in the normal comparison. But the only other thing I would say that I had to do at one point was trying to match up the providers that were included and not included. And I'll talk about that more when we get to the question about misleading or omission of data. But I had to do a little research on my own to go to actual providers and find out, are you going to be covered by Plan X or not? Or do you take Plan X? That kind of a thing. So that took a little bit of road work. And plus, you just want to, I'm kind of a loyal guy, and I like to stick with my current providers. But if they're not covered by the insurance I want, then I have to go look around. Then I like to get comfortable and find out more about my provider before I just pick one that might be down the street. So that was kind of my process and coming up with a solution to what I was looking for.
Bill, given that only about a third of Medicare beneficiaries actually shop for a plan, the effort and all the places that you went for information was pretty extraordinary. I think, thinking back at our advisory group, out of the 20 people who were there, a fair number had done some extensive information seeking like you. But how many hours do you think you spent on this during this open enrollment period?
Yeah, unfortunately, it's off and on and not continuous. But I mean, over time, I was able to, I tried to put some numbers to it. I would say 8 to 10 hours, depending, including visits to providers and things like that. And I did fail to mention that my finally, at the very end, what I did to get enrolled, though, was actually go back to the broker, because I happened to pick a plan that the broker I was working with did represent. And it was easier to use them than just to try to go to the plan myself and go online and do everything, because they already had all my data and they were able to just plug me in, send me emails, push this button, push that button, and it was very helpful. So that aspect of the broker was helpful, and I did circle back to them to do that. But that's kind of that would be my estimate of the number of hours.
Yeah. And you already mentioned that, there were some weaknesses and barriers from all the different tools and resources that you use. You already mentioned, not hearing from the agent that there were some plans they weren't talking about or selling. Was there anywhere else where you felt like that was not helpful? That was sort of misinformation or it just wasn't helpful.
Yeah, I think the term misleading is probably not an accurate. I mean, I don't think a lot of people were trying to mislead, other than, like I said, it was more like omission of information or outdated information. The provider data kind of threw me for a loop because you start the process and you find out, oh, my dentist isn't covered. Man, I guess I'm gonna have to change my dentist. And I start looking around and I ask my dentist, "Are you not taking Plan X?" And no, we're not. And then as the process rolls along, I happen to have a dentist appointment in December. I went and I said, "I just want to check one more time. This is the plan I selected. You really don't have this, right? Because I'm going to go looking for somewhere else." Oh yeah, we do take that. And so things change constantly, and maybe that's part of the problem. But it would seem like I don't know the process of getting a provider approved by a plan or whatnot, but it seems like it's not timely enough to make the decision that you need to make sometimes because it
Mhm.
changes throughout. I don't know what causes that delay. There could be a lot of good reasons for that. I don't really know. But just to have it not current and not so and to be subject to change was a thing. But working with SHIP was very good. I felt like that I was able to reverse engineer. Oh, what dentists are covered by this plan that it looks like I'm going to go with, and they could tell me that. And then that's why I said I went and made some personal visits to those dentists in this example just to see where I wanted to place myself. I had one all picked out, and then it turns out my existing one did take it. So it was a happy ending in that sense. But um, those are probably the main things. The other thing I think is that drove some of my decision making that maybe wasn't mentioned and maybe doesn't fall under this misleading category, but I have a particular type of surgery I want to have next year. Well, some places take Plan X, some don't. So you kind of have to do a little research on that and kind of make this all work together that it ticks all the boxes for the things you need in the upcoming year. It's a year to year decision. It's not like one year you're going to have the same solution you're going to have next year.
Yeah. Thank you for that. And I remember in our advisor group, a few of our advisors commiserating about trying to do this while also managing a chronic illness or an acute illness or a family or doing caregiving for a family member. So when folks wonder why do only 30% of beneficiaries shop, I think this really displays the just the time burden and the level of kind of health literacy and savviness and computer literacy that is that is required to have this what turned out to be a successful experience for you. Um, I just wanted to before we get into some other questions, Jack. There was something in the MA proposed rule that sort of said we want to consider ship counselors versus agents and brokers. They're very different. There's great agents and brokers,
Mhm.
but they mentioned something about the differences in training, maybe suggesting that ship counselors, because they're volunteers, don't have the right training. And I just wanted, if can you give a brief how are we trained as ship counselors, and can you trust a ship counselor just like you would an agent or broker?
The short answer to that is yes. I think you really can trust a ship counselor the same way you do an agent of brokers. We've got the same variation. We have people that have extensive experience. We have people that are less experienced. Excuse me. And the same way with agents and brokers. You've got some really good ones out there who are long experience, talking about these programs, and others who may be much more focused on work time, workplace insurance and insurance for people who are under 65 and have less involvement with the Medicare population. But we both groups have to pass exams to show that we know our stuff. So ship counselors are offered an extensive set of modules, online training that you can go through that will walk you through aspects of how Medicare works, how all the various deadlines, the timetables work, um, all the kinds of things you would need to know that reflect the kinds of questions you got. And then you have to pass a test. Um, it's a test that tests your knowledge. It's done, at least for our county, it's done as an open book test. So it's not necessarily testing whether you've memorized everything, but whether you know how to find the answers. And that's the way we really work. When I get one of those humbling questions that I don't know, the point is I know where to go and get the answer. And so we're tested, and we've got in our county, we take that test every year to show our continuing competency to be a counselor. And if you don't pass the test, you can't counsel beneficiaries. Agents and brokers also go through a testing process and a training process. And I don't know whether that one is more extensive than the other, but I would put any the average ship counselor up against the average broker any day for their knowledge of the program.
We had a question from the audience about whether the tests and training are the same nationally for all ship counselors.
They do vary. I mean, the training resources are there. They're organized through something called the SHIP TA Center and the Medicare Rights Center, which is an advocacy group and a resource for seniors and for senior counselors. Puts together a lot of those materials. A lot of their materials are also online for anybody to use, so that's another good resource for the general population. But they're the ones that put together these training modules, and those are available on a national basis. The actual way the testing is done, I think, is done differently, at least at the state level. I know our questions for our particular test are put together by a state panel that decides which questions to ask each year. But they're going to be comparable questions from different parts around the country.
Thanks. I want to get back to Laura. You mentioned these star ratings. So all MA plans get between 1 and 5 stars. Obviously, 5 is better. I believe the majority of plans do have up in the high 4 to 5 stars. And part of that is because these stars are not just used for beneficiaries to make a choice. They're supposed to represent quality, and plans get a quality bonus payment based on the stars. So they have a lot of incentive to get these high stars. On the other hand, they don't seem, most beneficiaries don't use them. So you just get a little more granular on why is it hard, when you ask beneficiaries, they say they're just not meaningful. I don't know what 4 stars means. One thing I would just point out is that their stars are on the contract level, so it could be through the average quality across 300 plans in 7 different states for some. But what are some just a little bit more on the star ratings and why those are hard for beneficiaries to use?
So the star ratings are sort of a composite across 40 or more different quality measures. So they're combining information about things like what share of people are getting a flu shot and what share of people are getting a mammogram, but then also like how many complaints the plan receives, how many people disenrolled, how people rate their plan in a survey. So it's like a lot of different pieces of information trying to come together into one broad rating. And I think it can be difficult for beneficiaries to know what that rating is going to mean for them because different beneficiaries have different sets of needs, right? A beneficiary that is going to mostly do a couple of doctor's visits is going to have a really different experience than somebody who might be hospitalized and need post-acute care. So it's just, I don't know that it's an easily solvable problem. But making it easier for beneficiaries to go down a level and see what the performance is on specific metrics could potentially help. I know Jack has also mentioned that he counsels people to use these more as a tiebreaker than as like a primary sorting mechanism, which I think is a reasonable way to use the star measures. On the quality bonus side, I have a whole hobby horse about how we shouldn't give money for that, but
it's just hard to have the same system being used for payment as for beneficiaries, I think. I'll just open this up to all of you, if you're thinking about a star rating, thinking not about payment, but just making it more transparent to beneficiaries, what the quality of the plan is. What are some changes to star ratings or additions to star ratings that could be really beneficiary focused that you might recommend CMS look into?
I mean, I think I'll pick up on one of Laura's comments. I mean, some of the examples she used. You rate a plan on what percentage of their enrollees get a flu shot. Well, I'm going to make my own decision about getting a flu shot. And that's going to be me. It's not a plan that's going to necessarily encourage me or tell me or you know be the basis for my picking that plan because more of their enrollees take flu shots. Now, the responsiveness of a call center or complaints received might be something that is so that's where you might think about trying to distinguish between things we want to know about plans for rating their quality. That's where, percentage of people that get a flu shot does matter. Although even there, they're subject to whether individual people are making decisions about that flu shot, and there's only so many things they can do to get that number up. So even that's can be questionable as a quality rating. But there is a difference between the things that might matter to me as a Medicare beneficiary looking at plans. I think there is a level at which the sort of composite rating and overall is this a 4.5 star plan, and that's a good thing, is something that like Laura said, I would recommend as kind of a tiebreaker, Matt. If there's a 2 star or 1 star plan out there, I may try to avoid that one even completely in when I'm counseling my clients. But I'm not going to make a lot of distinction between a 3.5 star and a 4 and a 4.5 star plan. I'm much more important to know about, do they cover the doctors that I want to see? Do they cover the drugs that I need to take? And those kinds of things and what are the costs to me? Those are the big factors that we want to think about when we're picking plans, whether as a beneficiary or whether it's me as a counselor advising clients. And then, yeah, star ratings can be that additional factor or tiebreaker when I've got 2 or 3 that look equally good on other factors.
Yeah. What about you, Bill? I know that looking at the stars was not all that helpful to you. Is there something in terms of outside of the things that you and Jack mentioned, like what does it cost? Are my doctors covered? Is there a level, is something around quality of a plan that could help you in some sort of a star rating system that hasn't been mentioned that you'd be looking for?
Yeah, well, one of the things that came to light in one of our preliminary discussions with this group that Jack informed me was that I could drill down into those stars and get to the different components and see how each one of those was rated. That would be important to me. It's kind of like when you're looking for an Airbnb or something like that, and you want to know or if somebody rates it low, why did they rate it low? And if it's something that seems superfluous or irrelevant, you can just ignore it. But if it's something pertinent to you, then you can make that application and utilize that information that way. But I would just like the ability, and apparently it's there, I just wasn't aware of it, to drill down a little deeper and see how those components are so I can prioritize and evaluate better. But by and large, I mean, there wasn't a lot of variation among the ratings. I mean, like Jack's between 3.5 and 4.5, they're pretty much all there. So without even knowing what was behind it, it was pretty much not information that I needed or used in my evaluation.
To Bill's point, it might make sense for the plan finder, instead of just displaying the one overall rating, there are then, I think it's 3 or 4 or 5 sort of sub ratings. And then you can further go down to individual criteria, but maybe something that displayed those subcategories as, they're a 5 on this and they're a 3 on that, would start to get to the better information that Bill was seeking.
Thank you, guys. We have a bunch of questions in the Q&A. So anybody who has a question, please put them into the Q&A. Here's one, maybe Laura, this is for you because you mentioned it. How do the panelists feel about the proposed rule revising record retention requirements for marketing and sales calls? Those recordings that you mentioned, and wondering specifically about impact for consumers.
Yeah, so what they're proposing to revise is how long that they have to keep these records. I don't know that that'll have any direct impact on beneficiaries immediately. I think the bigger concern would be the seeking comment on maybe we don't need to record these calls at all, which I think would make it harder for beneficiaries to get help if they had an experience where they felt like they were misled or enrolled in a plan that they really didn't intend to enroll in.
I think it
Yeah,
also
and
speaks.
you mentioned that the federal government can't, do oversight on the third-party marketers, but the MA plan is supposed to be doing the oversight on that. So I imagine those recordings would be helpful for an MA plan if they were trying to get to the bottom of maybe some something that happened in an agent or broker call.
Right, theoretically, they could do quality control. Part of the problem, though, in MA is that some of these third-party marketers don't work for an MA plan at all. They are out there on their own. Some of them are overseas, and they make their money by selling leads to agents and brokers and maybe MA plans. So there is no mechanism then, except maybe some other parts of the federal government could get involved, but there's not a lot of mechanisms to regulate that kind of activity.
I think
Jack,
I
were
know
you
what selling leads are, but can you just explain a little bit more about what that is?
Sure. So when they successfully reach a Medicare beneficiary, generally they're supposed to have the Medicare beneficiary agree to have direct sales calls made. So they put an ad on social media and get a beneficiary to put their number in it or something, phone number in return. And then they sell that phone number to an agent or broker or Medicare Advantage plan as like a warm lead for selling Medicare Advantage.
Got it. So just yeah, selling lists of people to call.
Yeah.
Okay.
Yeah, because one of the rules in the program generally is you can't do cold calls. You're not, now all of us who are beneficiaries get cold calls, and a lot of those are complete scams or otherwise illegal. But, you're not supposed to get cold calls. So these are the mechanisms by which you can, get a call that isn't a cold call that's based on what's viewed by the law as a request to get a solicitation.
Mhm.
There's also this change of having a waiting period between an educational event. I imagine that's like, come to this lunch and learn about MA, and when you actually when an agent or broker or some third party hosts, and then currently you have to have a waiting period, so you can't just sign them up right then or get signed up without knowing it. Um, Bill, have you ever gone to these kind of like educational events that might be hosted?
I have not.
Okay. And so, what are thoughts of our panel on why it's important to have those waiting periods, or is that a fine thing to get rid of?
I mean, I think the issue is, and you framed it nicely, you're invited to a session that is legally set up as and is marketed as a broadly informational session. Now, we run as SHIP some of these Medicare 101 sessions, and we don't do any selling, of course. It purely is an informational session. But other organizations that might be affiliated with or might be a broker organization can also run an educational session. And you think you're going to an educational session, and then maybe you walk away having been sort of talked into signing up. And so the idea of that waiting period is that we want to separate the educational process from the marketing process and the enrollment assistance process. So you go to the educational event, then you can create an appointment to come back and meet with the broker, who then may be a perfectly honest and capable person who can help you walk through your choices and get you enrolled in the plan you want. But you're not doing it sort of under the guise of being neutral educational process and then just sort of being swept directly into a sales pitch.
Mm-hmm. Okay, this is a question. What was that? So that from an attendee that Wyoming, sounds like it's their SHIP program, puts out a buyer's guide for Medicare beneficiaries in Wyoming. It gives great information on making choices in a much more readable format. And this is put out by SHIP. Is that a common thing that different SHIPs put out, either state or county-based information?
There is a variety of those kinds of tools out there. In Virginia, we have something that's a little more narrow than that, but the state insurance department puts out a guide to Medigap, Medicare supplemental plans, which is another, of course, part of, we're talking here more about Medicare Advantage, but that's another part of the array of options that people have. And they have their own plan finder, which is, I think, more user friendly than what Medicare has for looking at Medigap or Medicare supplement plans. And so that's something that the state insurance department, both that online plan finder tool and a printed or online booklet that goes through and explains. So yeah, there are some of these individual tools out there. I know Montgomery County, Maryland, where one of our colleagues serves as a SHIP counselor, has kind of a process they use where they invite people to submit their list of drugs during open enrollment. They'll analyze, run those drugs through the plan finder and send them back a list of the maybe 2 or 3 plans that best fit their needs. So again, there are different tools that are developed either by individual SHIPs, by states, and then of course there's some third-party tools out there that may or may not be affiliated with selling activities. There are groups like the National Council on Aging that have various kinds of tools available that are nonprofit, neutral, not trying to sell anything. And then of course some broker organizations might have perfectly good tools, but that is affiliated with selling particular plans.
Yeah. So in this discussion, we've been talking about open enrollment and shopping, and it's very complicated and hard, and we know that the federal government has a lot of changes to that. But kind of getting to a higher level on the MA program overall, this is a pretty successful program. More than half of MA beneficiaries choose to enroll in MA plans. We know it can be much cheaper for beneficiaries as they have an out-of-pocket cap on spending than if you were in traditional Medicare. So maybe just sort of, Bill, like, what do you overall think why do you enroll in an MA plan?
Well, I think it's a very important decision with far-reaching financial implications. So it's something you need to spend some time on and understand it better. And so I do my best, obviously, to save money for my family, but also to get the proper medical care for myself. And I think these plans are fantastic. When you start finding out about them, you wonder if it's really real. Like it seems so good. And so I think most of what's out there is really good. I find it helpful that moving from I used to be a participant in my employer making decisions to define a plan that's going to fit a broad range of employees with various makeup of that particular group. Now I can focus on myself and I can go out and look for what works for me and I can spend my time for my own benefit. And so any changes that would be made to the current process that would either take away my decision making or information available to me to make decisions or give latitude to brokers and others to provide information that perhaps is in their benefit or in their favor. I'm not in favor of any of that, but I think the things we have in place now are good. I think we could just make them stronger, perhaps provide some more resources. But I think one thing that needs to be addressed as well is, let's face it, most of the people that are on the Medicare plans are gradually increasing in age enough that there's going to be cognitive issues and things like that, and hard to make these decisions and assimilate all the data and come up with all the right answers without assistance. And so that's where SHIP comes in. Or for myself, for example, I help my mother make these decisions. My wife is the same age as me, not quite to the point of cognitive disabilities, but she doesn't. This isn't her area of expertise. So it's just good to have like my accounting and finance background to lay into it and understand it better. So I think overall, it's the plans are great. You just need to be able to analyze them and get the one that's best for you. And again, it can vary from year to year depending on your circumstances.
I'd really want to emphasize exactly what Bill just was talking about. You really need to continue analyzing your choice over time, because what works for you in 2025 may not work for you in 2026, and the 2026 choice may not work for you in 2027, let alone 2035. And so people do need to really think down the road. Now, that's one factor that comes up in that, is whether you would have an option to go from Medicare Advantage to traditional Medicare at some point in the future. Because the rules in most states do not allow you to have guaranteed issue back into a Medigap or a Medicare supplement plan. And so to some degree, a choice to go into Medicare Advantage is a choice you may not be able to undo in the future. Now, there are various exceptions to that, but it's those kinds of things that we really, as counselors, try to make sure people understand. It's both what your decision you're making for today, what's going to work for you today in terms of your current medical needs, your current drugs, your current doctors, and what are the implications for the future, both in terms of your need to continue shopping from year to year, and whether some of the choices you're making today may not be able to be undone in the future.
I think we have time for one final question. There's so many good questions and comments. Someone did mention, are you going to cover supplement plans, Medigap plans? And we are not going to cover that. It's a really important topic. I know Laura knows a lot about Medigap plans. These are the plans if you're in traditional fee-for-service Medicare, you can buy this plan to cover your co-insurance and co-payments, which can be really high in traditional Medicare. So we're not covering those today, but it's a really good question. And then one final question is about people who travel internationally or maybe live internationally, coming back and forth to the United States. How do you assess that what are your thoughts on that in terms of shopping for MA or traditional or different MA plans?
It's always important for people to understand that Medicare basically does not provide coverage outside the United States. So people traveling internationally really have to think about some other source of protecting themselves. And certainly anybody who moves overseas, is going to have some alternative form of coverage during any period that they live overseas. Now, there are travel insurance options and things where you can take care of yourself. Same things apply for traveling within the US. I mean, if you're in a Medicare Advantage plan, many of them that are part of national companies like United Healthcare and Humana and the Blue Cross family of plans will have reciprocal coverage all around the country when they're traveling. And of course, if there's an emergency, that's normally covered as long as you're within the US. If you sign up for a locally based plan like an HMO, like a Kaiser Permanente or a local HMO, there may be more questions there. What happens if I'm going to spend a month with my grandchildren in another state and I need to have a checkup for some kind of condition that I'm monitoring? Will I be able to do that, or will I have to wait till I come back home? Or will I have to pay out of pocket to do that? So those are questions that you should always ask if you're in a traveling situation and you want to be in a Medicare Advantage plan, particularly. But some of those questions are true with traditional Medicare as well, such as the international travel situation.
All right. And then one final comment from one of our attendees is that they see the star ratings as kind of like an Amazon review from other users. But I think, for me, I would think that ratings from other users are one of the things that I would pay attention to and will when I'm in the position of choosing plans. But this attendee says they rarely get a survey asking them to rate plans. Where do they get that information from the beneficiaries?
So there are two surveys. There's the CAPS survey, and if anybody remembers exactly what it stands for, please jump in. And then the health outcomes survey that go to beneficiaries, but they're just samples of beneficiaries. So yes, any given beneficiary has a pretty low chance of getting one of those in a given year. And they ask you to sort of self-report how your health is, rate your health plan, rate your experience with doctors, talk about wait times, those kinds of things.
Right. All right. Well, I want to thank you all for being here today and thank our attendees for participating in this discussion. Bill, especially, it's just so great to get your perspective, having been such a robust shopper uh, of MA plans and being able to share kind of the experience and what you got out of the different tools and resources. So thank you for that. We are going to close the webinar, and I just want to say that if this is our team, will be doing, we'd love for you to, if you're interested in our work and our blogs and our reports, we'd love for you to join our email list so we can let you know about any other events like this in the future. So thank you all for being here.